And we are live.
I'm afraid that not yet. We are live now.
Yep.
Perfect.
Good.
Thank you, Andres. Thank you, Jacobo. Please go ahead.
So it is my absolute pleasure to introduce to you Professor Jacobo Sitt. Professor Sitt studied medicine. Then he decided to study psychiatry, and during his studies, he said, "Well, maybe it's a great idea to also to do a PhD in physics and to become a knowledgeable person about nonlinear dynamics." So he became a huge fan of the brain during that process, I think. And then he decided to do a postdoc in France with Stan Dehaene, where he got really interested in consciousness from the point of view of neural dynamics. So his work has been dedicated to study the brain as a network that changes over time. And he has developed many interesting ideas. Some of them I particularly have been using for the last 10 years, including some of his metrics and some of his ideas. So it gives me, he's now a professor Les Sorbonne and also a researcher at the Paris Brain Institute at INSERM. And today he will speak about neural dynamics in the context of disorders of consciousness, I think. So I leave you all with Professor Sitt.
Okay, well, thank you very much for the invitation. It's a great pleasure for me to be here today, though remotely. And you know, I prepared a presentation for today's event, ranging from all the different methodologies we have been developing using EEG to study the state of consciousness of patients with lesions. And I will first introduce the challenge of this thematic, and then the different approaches using EEG that we have been using. You know, I will hint a bit some other, you know, different aspects and how they could be, you know, methodologies, how they could be integrated in the future or in the current conditions. But you know, I will try to focus essentially on EEG and tell you a bit, you know, like the story of our lab on the last 10 years. So bear with me. I will share my screen. The screen here, share. So you probably now seeing my screen. Okay, that's good. And good. So yeah, I need to go to the first slide, not to the last slide. So please let me know if you are seeing this right, because I don't have feedback. But in principle, I assume we are okay. So, I'm going to, the title of my presentation is How We Can Measure States of Consciousness and Ideas from Mechanistic Principles to Novel Diagnostic and Therapeutic Tools. Today I'm going to focus like the section, like this overall presentation, only on the EEG part. And, you know, like I said, I'm going to first introduce to you the problematic. So what do we talk when we talk about consciousness? So when we talk about consciousness, we are discussing, in fact, two complementary domains. One, the first domain, which is what most of the people work with when they work on consciousness, is the study of the content of consciousness. So the content of consciousness, a person is conscious of something specifically, in particular. And for instance, here I give you this example of a classical illusion where you can either see the train going inside the station, outside the station, in one direction or the other. And the only way I can tell whether you're seeing one percept or the other is by, you know, asking. and then like perhaps measuring something on your brain or using EEG or other modality, and comparing the brain activity associated to one condition or the other, and perhaps study how, like Andres does, like what drives the transition between the different percepts when you have a bistable perception like this, or use other techniques like subliminal images, or pathological conditions like neglect, where the subject is like not aware of the external world. So the only way to assess this, as I said, is the use of verbal reports. So asking you whether you are seeing the train in one direction or the other. And then we tend to contrast the unseen versus unseen conditions, like if it's a subliminal image and sometimes you see it, sometimes you don't, and you contrast when you see it versus when you don't, when it's exactly the same thing, in fact, presented to you. And then you try to associate the brain activity to the difference, to the actual perception, to the content of consciousness in particular. On the other hand, the other domain that I work with mostly is the domain of states of consciousness, and the domain of state of consciousness is larger in the sense that here I don't mind whether you are conscious of something in particular. What I do care is that if you are experiencing a subjective experience overall. So in other words, like what we typically call being conscious or not. And this is clear the case in most of the cases when you have conditions such as sleep or anesthesia or disorders of consciousness, which is the topic that I work the most. So in all these cases, sleep, anesthesia, disorders of consciousness, we could potentially, define, a unidimensional space, which is absolutely not sufficient to describe all the complexity of the domain, where, the subject is more or less conscious, and at some point there is a subjective experience emerging. In sleep, probably somewhere between deep and light sleep. In sedation, probably somewhere around light anesthesia and sedation. And in disorders of consciousness, we don't know. We tend to think that limit is set between what we typically call the vegetative state condition and the minimally conscious state condition, which it's defined by behavioral responses of the subject that then that gives certain evidence that it might be connected to the external world, though they are not definitive. So it might be the case that the diagnosis might lie somewhere like the threshold between having a subjective experience or not might be not between vegetative state patients and minimally conscious state patients, but somewhere within the minimally conscious state patients. So that's an ongoing debate. And that, defining that, thresholding where that is and what are the biomarkers that are reflecting that potentially, it's important not only for scientific purposes, but also because of clinical purposes and ethical purposes as well. So giving some feedback to the families, to the clinic, to the treating physicians regarding the actual state of the individual, whether he's conscious or not, whether he's going to recover consciousness or not, it's important by all means. And so the only way to tell whether the subject is actually aware of the external world is to measure responsiveness. So basically asking you the question, are you aware, are you conscious or not of the external world? Are you currently having a subjective experience or not? And then what we tend to do is do a contrast where the only minimal differential condition is the fact that the subject can reply to that. And of course, there are many things that are emerging, but we're trying to focus on the aspects where the only limit is a subjective experience and not so many other potential confounds, such as like when you try to equate the situation on the conscious content and you provide the same stimuli and you contrast when the subject reports being aware of the stimuli and not. So overall, the objective of my lab is to try to answer these questions. What are the necessary and computational properties of person to have a subjective experience, what are the limits of processing and the different pathological and physiological states, provide answers to the single patient condition, develop novel diagnostic tools, and then using all these elements, how to personalize treatment of this patient. So we work typically in three domains, all of them related to the study of states of consciousness. Like I said, like the big one is states of consciousness. Here in the hospital, we have access. We are part of a service that sees these kinds of patients, and we need to provide answers as well. And so this is our main focus. And we also work a bit on sleep and also anesthesia. And as you can see as well, like there are many modalities that are used. Like most of the work is using EEG, like I said, but we use a lot of fMRI as well, and more recently a lot of brain-body interactions, which are interesting factor because it could be a promising new avenue, because this might provide tools that are easy to implement anywhere in the world, and then combined with the right type of behavioral assessment that might be quite informative and quite easy to reach. So unfortunately, I won't have the chance to present this today, but I'm happy to share the papers and discuss this some other time. So I'm not going to go too much on the details on the characterization of disorders of consciousness. This is a classical figure where we tend to to associate our subjective experience, like consciousness on the y-axis and wakefulness, and these two things tend to go hand in hand, meaning that if you have your eyes open and you are and you have a behavior, you are awake, and then you tend to be conscious. So there's like a very strong correlation in most cases between wakefulness and awareness, which is a synonym that we tend to use for consciousness. But in disorders of consciousness, what we have is a dissociation. So these patients are basically awake, meaning that they have sleep and wakefulness cycles, and they have their eyes open, and they might have some kind of non well-defined behavior, but they don't provide any evidence of being conscious of the external world or aware. And as you go up now with being awake but more and more aware, you go from vegetative state to minimally conscious state and potentially to a fully conscious individual. So, but then this representation, like I started with a one-dimensional representation, then we went to a two-dimensional representation, and there's clearly recent papers and clear evidence that in fact this two-dimensional representation is not sufficient, and we need to in fact use a multi-dimensional approach to characterize these individuals with several dimensions characterizing cognitive processes and either conscious or unconscious, but basically which are characterizing the different groups of vegetative state patients, minimally conscious patients, and other kinds of individuals. Nevertheless, even with all these advances in terms of characterization, we still have a huge amount of misdiagnosis. Like a report which has a bit of time already shows that without proper medical training, doing a characterization of these patients using a very detailed behavioral characterization, you still have 40% of misclassification, meaning patients that are diagnosed as being vegetative, but in fact are not, they are minimally conscious. And this is why we use very specific description of different functions, behavioral functions on these patients, and this is called the CRSR score, and the combination of all these will provide a more descriptive way to characterize these patients. But yet, even when you have a very full described condition of the behavioral characterization of these patients, there was a paper already 10 years ago, like 15 years already, where they show that in fact that you can grab a vegetative patient and sorry. I don't know why. Okay. Right. Still good. No? Yeah. And I'm sorry for this. Right. So that you can grab a vegetative state patient and ask him to, imagine himself playing tennis or navigating his her house. And then in normal healthy individuals, you have a typical dissociated activation on the brain when you are imagining one or the other condition. And what they found is that in a vegetative, behavioral vegetative patient, you can have like the same kind of activation that you observe on a healthy individual, meaning that in fact you can follow commands with like a vegetative patient can follow commands, even though it doesn't have like a very characteristic behavior. So this has been called cognitive motor dissociation. Basically, patients who have a dissociation between the cognitive state and the motor output. So this creates a huge challenge because now behavior is clearly not sufficient. We need to have like a complementary tools and new imaging tools to characterize these patients. And fMRI can be very complicated to implement on these patients. So all points to EEG as a right kind of tool that we should use with these patients. So our approach in the hospital and at the ICM is to try to, when we assess a patient like this, we tend to assess him or her like during a full period of a week, where we combine lots of EEG assessments and behavior assessments and other modalities such as positron emission tomography or fMRI, and stimulation techniques such as TDCS, which we will see during my presentation. So at the end of the day, this question of patients is as a double input, double challenge. The first is fundamental. So this is an interesting model for us to understand what, how, and where consciousness occur in the brain, but also like provide answers at the single patient level, whether to answer whether the patient in particular is conscious or not, and provide elements for the families and the doctors. So with this, after this long introduction, the different research lines that we are developing are essentially the ones associated to neurophysiological signatures of the state of consciousness, which is basically using EEG to characterize these patients, to try to perturb the system using different techniques. When I say perturb the system, I mean perturb the brain of the patients using essentially TDCS stimulation to change a bit the dynamics of that brain and see how it reacts. Then markers coming from brain-body interactions and fMRI dynamics, which unfortunately I won't be presenting today. So how do you try to derive markers for the state of consciousness in patients? So like Andres said, my background, it was a mix of psychiatry plus physics. And when I arrived here to Paris 13 years ago, I was confronted with the challenge of proposing biomarkers of the state of consciousness and testing that on our interesting database of patients that we had here on the hospital. And for that, working with Sam Mehan and Julian Nagash, we said, okay, let's try to be a bit of theory agnostic, in the sense that there are very lots of theories of consciousness, and all of those theories have different predictions. So it was sort of the embryo of the current competitions of the different theories. But in my case was, okay, let's try to find what's complementary of them, and then just extract from the different predictions that different theories have, and extract those ideas, try to transform those ideas into well-defined biomarkers, and see what works and what doesn't work to characterize these patients. And furthermore, try to see if by doing synergy interactions between the different biomarkers, whether we could do even better. So, what are the common predictions that all the different theories have? Well, basically that, a human, in order for a human to be conscious, you need to have the information between the different brain areas share, meaning that like one area needs to interact with another, and then that there should be a certain amount of complexity on that signal as well, in order to represent the external world, like with a level of complexity. You need to have a certain amount of complexity on the ongoing brain activity. Then, like, for us to operate on the information that we obtain on the external world, we need to have some sort of maintenance in time of that information. And then finally, from the theory of Nico Schiff, also that when it's more basic, that a certain frequency ones need to be present from the interaction between different brain areas, and that should play an important role. So then, like I said, then the idea was to say, let's try to combine all these and provide a classifier or some sort of like optimization of the different biomarkers that we have developed. So let me, first tell the long story, and the long story starts with Tristan Beckenstein here in Paris. He was here for a year before I arrived. We didn't have time together here in Paris, but we knew each other from before from Argentina. And Tristan, when he was here in Paris, he developed a very clever protocol, event-rated protocol, which is basically an oddball paradigm with another layer of complexity. So in a typical oddball paradigm, what you have is a series of auditory tones, and then suddenly you have a tone which is different, and that tone that is different, like that you have here, for instance. What it does is that it triggers two types of responses on the brain in terms of the evoked responses. The first response is a mismatch negativity. It's a negativity which is frontal and occurs around 150 milliseconds after the onset of the deviant tone. And then you have a second response, which is called P300, and which can be divided in P3 and P3V, and it's a positivity in the back of the scalp around 300 milliseconds after the onset of the deviant tone. And then it has been known for a while that when you are distracted and you are like sleeping and in all sorts of unconscious conditions, you still have this mismatch activity, but the P300, the P3V disappears. So basically, the first one seems to be like more associated to the automatic detection of change by our auditory cortices, and the second one to our subjective experience. An interesting adaptation that Tristan made was to say, okay, let's do the regularity be defined by a second level of regularity. So not like the sequence of tones, but the overall what's frequent and what's not frequent. Like for instance, here in this condition, what's frequent is to have 4 tones equal and the last tone different. And then like you have this condition in which you have 5 tones the same. So overall, this stimulation in this context is locally standard, meaning that it's the same from the previous tones, but it's globally deviant, meaning that overall the full set of 5 tones is different to the previous conditions. And vice versa, here you have like a condition where like the last tone defines a breaking of the local regularities and a breaking of the global regularities. So the interesting thing here now is that you have 4 conditions: local standard, local deviant, global deviant, local standard, global deviant, and local deviant, global standard. And then by mixing all these different conditions, you can now define local regularities and global regularities. And the interesting thing is that local regularities elicit an MMN, and global regularities elicit a P3V. So we can dissociate the two, which we couldn't be dissociated before. And the interesting thing is that like we started to use this, they started to use this, and I continue using it since on patients. And what you see is that you typically on a global effect, you have a strong global effect on conscious control subjects, and you can have vegetative state patients with either no global effect or with a global effect. And in fact, we demonstrated more recently that when you see these, like the chances of recovery of the patients are much higher, meaning that there was clearly something different on those patients, and the MMN is not so predictive in this case. And then so we have like interesting results in that sense. So far, those were results on classical ERP analysis, and then on 10 years ago, with someone who's extremely brilliant, John Remy King, we started to use machine learning techniques to see if we could use this at a single subject level. And the interesting thing is that, for instance, what you see here is that it's really clear that when you do an average at the group level, you have an increase of the mismatch negativity with the state of consciousness, but it's not so clear for the P3V. And why is that? Why is the case that there is no emergence topography at the global level? Well, the reason is that you have all sorts of inter-subject variability. Some subjects have an MMN with a topography, some others have with a certain time frame, and some others have an MMN, a P3V with a different time frame. So when you combine everything, you have just really nice topographies, but at the single subject level, not so much. So for that, we started to use multivariate analysis, and this is a bit of old news now, 10 years later, but the idea is you can combine the signal from several sensors and then provide a classifier that is good to discriminate one condition versus the other. And so, what you observe here is that even though, like, when you do the average at the group level, you have this, like, very smooth type of transition between the different groups, it's not so clear when you do a decoding at a single time point. Like, now you have a clear gradient between the different groups of patients. And then furthermore, in the global state, you have a significant effect in some MCS patients. And in fact, when you observe how many patients have a global effect, you have 50% of the conscious patients they have a global effect. Only 50%, which is that tells you a bit about the false negatives that we could have on this using this technique. But in terms of the information you can extract, like 14% of the vegetative patients do have a global effect. In fact, those patients are likely to recover. So there is a first level of interpretation of our data that we could do using classical ERP analysis combined with machine learning techniques. And then more recently, the idea was to extend this idea of using ERPs with different protocols, a bit matching the proposal of Tim Bain. And Claire Sochan provided this nice paper where many protocols are used, and you can observe how good the patients are on the different protocols and characterize the patients by their performance on the different cognitive protocols and do a better characterization in terms of what we call neuropsychological assessment of the patient, but without language, which is something very powerful, I believe. So that's so far what we have done and we continue doing using ERPs and cognitive characterization of these patients using EEG. But what about the predictions of the ongoing brain activity, of what should be the dynamics of the brain activity on a conscious patient compared to an unconscious patient? So we tested the second prediction. The second prediction was to test whether the information sharing across brain areas would be relevant or not. And then we developed this technique that I'm very happy that some other people are using it after we develop it. And so what we decided to do, it's okay, the EEG is quite noisy, and it's way noisier when it comes to clinical data. And if you want to compute really if two areas are interacting, you might be lost on that noise. So what we did is to do the composition of the signal into symbols. And the symbols are basically representing the local dynamic of the signal. And what you can now do is, once you have a characterization of your signal by the overall local regularity, the local dynamics, see how frequent one symbol is when you have another symbol in another area. So, for instance, here on this example, every time there is an A, here there is a V there, and so on and so forth, which you can see here on this matrix here. So A associated to B, B to C, and so on. And then you have this non-trivial association between one symbol and the other. And then we wanted to say, let's penalize the common sources. And the best way to penalize common sources is to penalize trivial associations. And trivial associations is to have exactly the same thing in two sensors. So what we do is basically penalize the diagonal. So when the signals, sorry, the symbols are the same in the two sensors, the measure is penalized. So we did that, and we have a striking. We believe we were striking results because we have a huge transition in terms of the amount of information that it merges from one location to the rest of the scalp. Here, what you're observing is how much there is from this location to the rest of the scalp, and then you have this strong transition between vegetative patients and minimally conscious patients, which is afterwards continues to grow, but it wasn't it's interesting to have the transition here, and then you could do this interaction between areas that was later replicated by other groups, which has a clear transition in between vegetative patients and minimally conscious patients. And I'm not going to go into the details here, but that we have shown that this result is still valid independently of the etiology of the patients, independently of the level of the amount of time after the lesion. And interesting, one of the key predictions from the different theories of consciousness was that the space should play a role, meaning that if you have two areas that are very close to one another, then it shouldn't be relevant, the information transfer, but the longer distances should play a stronger role. And then we demonstrated exactly that in fact, when you do an analysis at longer distances, there is a certain point where the amount of information shared between the areas, suddenly there is a gap between vegetative patients and minimally conscious patients and conscious individuals, and then that's sustained for even longer distances. But there is a sort of a limit for short distances. So the next step was to go beyond the single markers, and what we did is to compute 92 markers. And what you observe here is a combination of ERPs, frequencies, spectral characterizations, measures of complexity, which I won't go into the details of the measures that we developed, and the connectivity measure that I just mentioned. And these are the topographies associated to different groups. And then what you can do is reduce this information by doing the average value at the whole scalp, and using the distribution to see whether they are relevant to characterize the patients. So what you see here, for instance, is that complexity measures, for instance, the farther they are from the central value of 0.5, the better they are for characterizing the state of consciousness. So we have stuff that it's really relevant, and some other which is not. For instance, complexity in certain frequency bands is more relevant than other. Lower frequencies, essentially alpha seems to be very relevant. Delta, on the opposite direction, seems to be very relevant. Interaction between brain areas, it's very, very relevant, but only in low frequencies. In higher frequencies, it's less relevant. What you see here is the comparison of the WSMI, this measure that we proposed, with 3 other measures of connectivity, and you see the rest of the measures of connectivity were not relevant to characterize the state of consciousness of these individuals. So, meaning that there is something specific on that type of measure. So then we tested the idea that more is better. The idea that when you combine all these, you can have better performance for classification. And furthermore, then when you can compare now the diagnosis at a single subject level, and the diagnosis at a single subject level, we focus on the vegetative patients. And we observed in 2/3 of the cases, we have a match between the diagnosis of the doctor and the diagnosis of the system. But in 1/3 of the cases, we don't. And in fact, when you now look at the recovery of these individuals, you see that the chances of recovery of the individuals when you have this mismatch is much higher. Meaning that, in fact, that there seems to be something there when we see something on the patients that is not observed on the behavior. And more recently, we have, and this is like this in this last paper, you can find all the methodologies online and the GitHub and all the different ways to compute all the different markers. But we have shown that the performance stays more or less the same when you go from 256 electrodes, which was the original publication, even to as low as 16. With 8, we have a slightly worse performance, but still sufficiently good. And you can use very short recordings and still have a really nice performance. And we have demonstrated that this can be validated without out-of-sample validation. So we use our classifier trained on one dataset, or dataset in Paris, and that was in the first paper, 2014, were 200 patients, and then in 2019 we revalidated to 100 new patients, and even more we validated to data coming from other centers from Liège with 80 patients, which are in a different environment with a different amplifier, and we get similar performance in terms of prediction. And I'm going to skip this because I think we need a bit of time, and I think that the story here it's more cohesive. So we are now developing ways to provide these tools to the users, and the project is called Neurometers, and the idea is that you can now transform all these into a web-based server where you can upload the EEG of a patient and have these all the markers computed and the prediction for that patient in particular compared to our database, and we are trying to combine that with ways to automatize the process of providing stimulation to the patients to do an ERP experiment, for instance, with the local global protocol or motor command protocol, where you ask the patient to imagine moving his hand or her hand or feet and see whether you have a different dissociated activation in one condition versus the other, and see if he can follow, she follow command. So it's basically an automatization of the pipeline that we are proposing, and there is a demo that you can see online. There's also the GitHub with all the elements that are part of this pipeline, and then this is what the web server looks like. So there's a list of recordings, and then you launch the analysis, and at the end of the day, what you obtain is a summary of the analysis with all the markers and a prediction for that patient in particular. And so we are working with lots of centers with this topic, and we're still open for continuous collaborations in that sense. So let me do a last pass on the idea that you can perturb the system and see how it reacts and use that to assess the patients. And then there are two ideas of this perturbation, and then I think one of the biggest work on perturbation is the work of Marcello Massimini and Mario Rosanova, where you do a TMS pulse on the brain of the patients, and you see how the wave reacts. And then I'm happy to discuss this if needed. And it's a huge and amazing tool. But here it was more like saying, okay, so there are potential tools to treat these patients, and they seem to be useful. There was a couple of papers in the last decade showing that if you do 20-minute simulation of these patients using continuous current from frontotemporal areas to somewhere in the back, and the idea is to somehow enhance the excitability of executive areas. you can have a good response on these patients. But no one knows the mechanisms, and no one knows why it works in such a small amount of percentage of patients, and how we can improve that. So those are open questions. And so I'm going to show you in this the figure here. So we basically did an open label study where we stimulated patients with TDCS using the protocol proposed, and 60 patients, and 12 out of the 60 patients, we can call them responders, because basically this is the CRSR before and after the stimulation. So you see that, in many cases, the patients are basically in the same condition, so they are not responding. We call them response negative. And in many cases, in some cases, 1/5, you have an increase of the CRSR, which is the behavior characterization. So if you can also see it in the form of how many patients were vegetative before, how many MCS, MCS plus, and exit MCS, and then there is clearly an increase, an overall improvement of the patients compared before and after. But this is open label and has difficulties, etc. So what we wanted to see is, in fact, our EEG markers are in fact responding to the stimulation in the way we believe they should. So what we did is essentially to do an interaction, so which is basically the responders contrast after versus before, and the non-responders as well, and then contrast responders versus non-responders. So basically, you want to see in responders what changes after compared to before in comparison to the non-responders. And what we focus is on the typical markers that we use, and then what you see is exactly an effect on the markers that we propose. We see a decrease on the power on delta power on this double contrast, and we see an increase in theta and alpha, which is the specific bands that we are trying to push. But furthermore, what we see is that when you do this connectivity analysis, this is what you see, like the double contrast. You see a huge difference on connectivity on the patients that are responding to the stimulation compared to the ones that are not responding to the stimulation. And this is what you get after versus before for non-responders, and after versus before for responders. So it's clearly the case that there is some specificity on these markers. And in fact, if you want now to understand why it works and why it doesn't work, so we need to, with the help of Lucas Parra, try to model the currents of the current of the TCS stimulation on the scalp and on the brain, using the specific anatomy of the patient. And what we observe is that the best predictor that for response was how many current actually got to the cortex. And this is important because, in fact, we tend to use one solution fits all for TDCS, or some this could be done. And in fact, like the fact that you can have we have lots of variations with these patients in terms of anatomy, and it's crucial to take that into consideration to make sure that you maximize the amount of current that reaches the cortex. So I still have 5 more minutes, I see, and I'm going to take that into advantage to show what I didn't show before. And that's the only, the latest thing that we are trying to, one of the things we want to develop is to try to see, okay, so we speak a lot regarding states of consciousness. And the interesting thing is all these biomarkers that we propose can be computed with temporal precision as well. So can we now use those same markers to characterize the access, like perceptual consciousness, like the access to a specific content? So if we can now, let's say, for instance, the amount of connectivity between two areas, it could be the case that it's relevant for overall subjective experience, but it's not relevant for the access to a specific subjective experience. So what we are doing is we're trying to propose a space in which basically we can lay now down the different biomarkers that we propose. And so what we do so far is to use only these dimensions. So basically, if a marker is good to characterize MCS compared to BS, it should be like somewhere around here. Like if we put on the x-axis is the AUC on the contrast of MCS versus BS. So if it's a good contrast, if it's a good marker of state of consciousness on this clinical condition, it should be somewhere around here. Like for instance, complexity could be somewhere around here. You have to be more complex to be conscious, or it could be somewhere around here, like for instance, delta, which goes on the opposite direction, meaning that if you have more delta power, it's more likely for you to be unconscious. And then, like what most people tend to do is that, like when you contrast the conditions of content, you work on this axis alone, only the y-axis, and you say, okay, if you have a P3V, then it's more likely for you to be conscious of something compared to when you don't have a P3V, then you're not, and or also connectivity measures, etc. And the interesting thing is now we can use the same EEG markers, for instance, in both conditions, in both contrasts, a contrast of state and a contrast of content, and see if basically they go hand by hand, meaning that, for instance, if complexity is relevant for content and state, should be around here. If power in certain frequency bands is relevant, it should be around here. But we tend not to have, we believe we shouldn't find stuff here, basically like markers that are anti-correlated, meaning they are increasing with the state of consciousness, but decreasing with content. But in fact, we do, and there are plenty of those. So what we have is like lots of markers that are relevant for content of consciousness, like for instance, gamma frequency, which is, we believe that that was relevant, beta or some measures of complexity. Power, like activity in delta power, seems to be anti-correlated, but that's sort of fine because the P3V can be seen as a very slow frequency thing. But then we saw that in fact, like there are measures such as connectivity measures or complexity measures that actually are good to characterize a state of consciousness. So basically, when we are conscious, when the subject is conscious, are higher compared to when the subject is globally unconscious. But in fact, on the same subject, when we contrast the fact that she reports seeing a stimulus versus not seeing the stimulus, they go in the opposite direction. So in fact, so that gives us a bit of like, a more detailed description of what is behind these different biomarkers. And it seems that, that some ideas of, bottleneck and that the fact that we can only be aware of a certain amount of things simultaneously, and the fact that when we in fact access something specifically, we tend to modulate like the block our capacity to interact with the external world, and that's reflected on a relative decrease of certain markers that are associated overall with a global state of consciousness. So we are trying to navigate a bit now the space in between the study using the same markers to study global states of consciousness, but also the specifics of contents. So with that, I just have a couple of take-home messages. First of all, like it seems that now EEG it's an interesting tool to characterize these patients. That there is room for the translation of predictions of theories of consciousness into well-defined biomarkers that are can be validated with out-of-sample data. That we are mature enough to provide like automated web-based pipelines, which basically democratizes the process of using these tools. One of the key limitations of the work of research teams with these patients is that you propose something, but then like to reach the clinics is very difficult because there's still a huge gap between the research lab and the clinical lab, and developing tools like this makes life easier. And then I didn't go into the idea of brain body markers. Sorry for that. But finally, I want to push this idea that to assess these patients, we need to go towards a personalized, multimodal, hierarchical diagnostic and prognostic tool, and we need to start with things that are easy to implement, and you can, provide increasing levels of description of the patient. And the easiest way to do is behavioral assessment, and we think we are getting there, and then providing tools to quantify clinical EEG and physiological signals. And then the next thing on would be to use EEG and ERPs, and then we can go to other modalities that are more difficult to implement, such as fMRI, PET, TMS, and EEG. And the idea is, as you go up, you might reduce the uncertainty associated to these patients, but as well increases the complexity of implementation, which we need to somehow balance between these two. So with that, I think very much the people who have worked with me in the last 10 years, and I'm happy to take questions.
Thank you. Cannot clap anymore like in Zoom, right? That you put the
I see a one hand here.
Yeah. That's great. Well, we have questions for you.
Yes.
Now, so I'm gonna read them to you.
Okay.
So one, how complicated it's to use these measures in hospital? How feasible it is in practice?
Okay. So I gave a hint of that. So like for a clinician to implement all these is clearly unpractical. You need to have a postdoc or someone who's actually geek enough to implement this from GitHub and adapt to your pipelines, and which we provide GitHub and all of that for the people who really want to get her hands dirty. But we also try to provide the tools to simplify the process. I mentioned the web server, which is designed for a clinician to basically upload clinical EEG or high density EEG and get everything done.
Okay. Another one related to that is, what are the challenges to implementing these measures in developing countries such as those in Latin America?
So I come, maybe my accent reveals it, but I come also from a Latin American country, from the other side of the Andes, you are
we are from the other side of the Andes.
Brothers, eh? No, I'm from the other side of the Andes. We have the joke that you are transandinos, I'm cisandinos.
Yes.
So yeah, that's developing these things in doing a regular EEG on the clinics on developing countries is a challenge, and that's why we're trying to provide tools that are even easier to implement. Just putting 2 electrodes on your chest, recording the heart, but associate that with the right kind of cognitive stimulation, and see if there is a modulation on the heart activity of the patient when she is processing an external stimulus. The tools of automatic analysis also simplifies the process a lot, because now we are ready to work with clinical EEG, which is a classical standard EEG that you can have on a patient, and that's all part of the same deal, trying to provide these things to everybody.
Yeah. Another one. What is the difference between using information measures and classic synchrony measures to understand differences between states of consciousness?
Right. So my experience with classic measures, and I'm not saying it's absolutely the case, is that they are less powerful for noisy conditions such as this one. There were really nice papers, from one of them from Andres, comparing, WSMI with other measures of PLI, PLV, etc. And there are advantages and disadvantages on each of those. The reality is that these information measures, such as this one, are focusing on nonlinear interactions between brain areas, and those nonlinear interactions between brain areas they seem to be more relevant for global states like this. But for perhaps for access conscious on or other stuff, it might not. So they are clearly complementary, and there is an interesting room to navigate between the two and adapt them to your specific question. For clinical conditions with noisy data, this reduction of because there are two steps on the WSMI. First one is the reduction of the signal to a series of symbols, which in a way you lose a lot, but you increase your SNR a lot as well. So when it comes to signal, very like noisy signal like this, this might be relevant. And then there's a layer of information theory measures, which basically you can prune that to highlight the nonlinear interactions or the linear interaction between areas, which probably they will be associated to different cognitive processes.
And the last one from Christian from Talca, Chile. He says, "Thank you for the interesting presentation. What are the recommendations to initiate young researchers in the study of consciousness?"
I'm not sure it's the right time.
That's true.
Okay, if you're following but like I think it's a beautiful community that we have, used to be at least. But please reach out, there's a plenty of Latin Americans distributed in the US and Europe that are working on the topic. They can give advice. First of all, like the first advice that I always gave and I still give: learn to code, learn to use Python, learn to implement things yourself. This is quite necessary. There are plenty of books for exploring and presenting the big questions and all the philosophy behind, which are really motivating, Dennett's book and others. And then just don't be afraid. There's plenty of people in Chile working on the topic, in Argentina, and go ahead, bring down walls, send emails. If you don't get response to your emails, send them again.
Yeah, that's how I got in. And there is one more. Has perturbation been attempted in patients using TMS protocols?
Sorry, can you repeat?
Has perturbation been attempted using TMS? So basically,
yes. So first of all, there are two approaches on TMS. First approach is what I mentioned, the approach of Marcello Massimini and Mario Rosanova, which is you can use TMS as a very strong, like throwing a rock on a pond, and you can see how the waves propagate on that pond. And what they measure is the complexity of the propagation of those waves, and they use that to quantify or to characterize the state of consciousness of these patients. That works quite well, and I think there are two reasons why it works so well. First of all, is the advantage of not going through the senses, not going through filters that you can have on the thalamus and on the signal. So basically, the brain is not used to process that, and that somehow amplifies. Also, the fact that TMS is super strong, so you have a super strong signal on the brain, and then you have an SNR of that ERP, which is quite high. Implementing this is quite difficult. So after 10 years, more or less, since the publication of that paper, there's still only one site developing this, only one or two. So which is, it tells you something about how difficult it is, and also tells you something about the previous question regarding how these ideas, how to implement in underdeveloped countries and things like this. So it's quite difficult. The other aspect is to try to perturb using TMS, using repetitive stimuli, and see if you can induce certain frequency bands. So there are a few papers out there, not very strong results so far regarding if this could be or not a useful tool for the patients. Again, it's easy, it's very difficult to implement. TCAs is much easier, it's much cheaper as well. That you just put a sponge here, sponge there, and you put a battery between the two sponges. That's it. A bit better, but in principle, that's what you do.
Mm-hmm. Okay. So Thank you very much, Jaco. It's been great. I know it's late in Paris, but thank you for the great presentation. And I think more clap.
Thank you.
Thank you very much, Haku. This is our farewell from Cutting Gardens. So it's a very special activity for us, this last session. Thank you very much.
My pleasure. Bye bye.
Great evening. Bye.